Welcome to video 4 of the SRPC COVID curriculum. This video will focus on the protected code blue and crisis resource management. The contents of this video will first discuss the new challenges that we face in the COVID-19 pandemic and follow with various suggestions regarding methods used to mitigate these challenges. If your local hospital has developed policy around code blue in the era of COVID-19, that will supersede some of this content, but there is still useful information in this video. And now to contextualize this video, the definition of a protected code blue is that it rebalances the mentality to focus more upon provider safety. We'll actually start by talking about crisis resource management in the era of COVID-19. Many things around resuscitation have changed because of COVID. We'll break this down into the medical piece, personnel, communication, cognitive load, and time issues. We'll start with the medicine. COVID is completely novel, and we don't have robust evidence to use when treating these patients. The guidelines and policies and conflicting expert opinion seems to change almost weekly. In addition, the physiology, for example the silent hypoxemics, are difficult to comprehend and clinically interpret, and it's hard for us to assess the benefit of a trial of resuscitation and balance this with provider risk and exposure. Regarding personnel, COVID has really intimately changed the personal stake that we have in patient care. There is significantly more risk now to ourselves and our colleagues when resuscitating a patient. The overall goal is to minimize staff exposure, but we have to balance this with the duty to patient care. When wearing full PPE with an N95 mask, communication is extremely difficult and borderline impossible. There is significant difficulty communicating outside of the room, for example, if you need extra hands or to speak to consultants. In most of us, the process of running a code blue is typically System 1, or fast thinking. COVID has changed everything, and now we are all forced to do something different and use System 2, or slow thinking. We're all slower, and we must be more deliberate with how we think and how we act. Many team members often second-guess what they're doing and don't carry themselves with the same confidence that they used to. You should not expect the same efficiency of yourself or your colleagues. You should expect much higher cognitive load than normal in your team, and your role is to be a clear leader when everybody else is hesitant and pensive. In addition, the full set of airborne PPE is hot and it adds to physiologic stress. Issues with time. Now, donning and doffing PPE, as we all know, takes a significant amount of time. Everything else is also slower. Medication administration, equipment retrieval, and the logistics of transport. Everything moves in slow motion. We really aren't used to taking time when a patient is critically ill, but we must accept this for the safety of our team. Now that we've spoken about the issues that COVID brings up, we'll speak about the potential solutions or things that might help us in these situations. A pre-brief is exceptionally helpful in COVID. It allows for the development of a shared mental model before even entering the room. It allows the team to know what equipment to gather, to assess the personnel requirements, and for the team leader to assign roles to each member of the team. You should consider including a dofficer and/or a donning and doffing buddy system during this pre-brief. This will allow you less time in the room exposed and less time in hot PPE. The pre-brief also allows you to discuss contingencies, what-if situations, for example, if you have an exposed team member or if there's a ventilator circuit disconnect. There are many tools that we've discussed for cognitive offloading. Checklists are useful for equipment gathering and critical steps, like PPE donning and doffing. Grab bags can massively simplify equipment gathering, and you can also even consider airborne PPE grab bags. Flowcharts are useful for a shared mental model. They serve as a roadmap for the resuscitation. With all of these things, an organized structure that is consistent is key. It's usually a good idea to dedicate one person to run the checklist and/or flowcharts. These tools are only useful if all team members are willing to use them and if the use of these tools is actually practiced. And this is why our curriculum focuses upon simulation. Developing a hot and cold team is something many institutions are doing because it allows us to minimize provider exposure. The idea behind this is having a runner just outside of the room or in the antechamber in full PPE. These people are not exposed to COVID, but they're available to retrieve equipment or immediately assist in the room if required. And finally, you should consider alternate methods of communication. Many sites have begun using baby monitors, a cell phone in the pocket under PPE, whiteboards visible from outside of the room, and/or predetermined physical signals for communication. Now let's talk about the actual code blue. There are a few changes to how we resuscitate patients. In general, the airway is now given more priority compared to a normal code blue. You should also pause compressions during any airway manipulation. When you consider the management of out-of-hospital cardiac arrest, consider stopping CPR at the door, inserting a supraglottic device and a viral filter at the door, using point-of-care ultrasound for a binary yes or no to cardiac activity as a data point when considering a trial resuscitation, and you should only resume CPR once you are in the negative pressure room or your resuscitation room. For in-hospital cardiac arrest, you should be wary of the relatively poor sensitivity of the actual COVID testing swab. Studies have shown its sensitivity for detection of COVID to be around 60 to 80%. Your take-home point here is that a negative swab does not exclude COVID. You should have a discussion within your hospital about whether or not you consider all code blues to be potentially COVID positive. In the event of an unexpected arrest, you must force yourself to pause. Your instinct will tell you to jump in and try to save the patient, but in exchange, you risk contaminating yourself, your family, your entire emergency department, and this cannot be the case in the era of COVID. Unless everybody in the room is in full PPE, do not start the resuscitation. All right, let's summarize our video on the protected code blue and crisis resource management. In the era of COVID, you must shift your mindset. Protected means prioritizing provider safety. Remember to pre-brief to develop a shared mental model before you go into the room. You should develop and practice cognitive offloading tools, as well as alternate methods of communication within your department. Consider what major factors there are in your decision-making process regarding a trial of resuscitation in the era of COVID. You should also consider simple but relatively effective airway management with an SGD and a viral filter at the door. And in general, the take-home point is pause. Be deliberate. This has been video 4 of the SRPC COVID curriculum. Thanks for your patience, your enthusiasm, and your participation. We're excited to start working with you soon.